Hello, everyone. Thanks for joining us today for this presentation on spinal cord stimulation, advancing innovation for chronic pain. My name's Dr. Bailey. I'm an interventional pain specialist here at the Pain Institute of Southern Arizona. And we're going to talk a little bit about the history of spinal cord stimulation, as well as the revolutions in technology that are enabling patients to live a better quality of life and reduce their pain. Move on here. Share the screen so you can see what comes up next. And our next thing here is to introduce myself. I'm Christopher Bailey. As I mentioned, I work here at the Pain Institute of Southern Arizona, taking care of fine people in the Tucson area. I went to medical school in Rochester, Minnesota at the Mayo Clinic. And I did my anesthesiology residency and my interventional pain fellowship at the Mayo Clinic as well. This is our vision statement. And I think this is important to read to you and kind of talk a little bit about it, that through compassion and innovation, we'll make a meaningful difference in the lives of individuals and communities. I think this is really important to focus in on a little bit and to let you know what we feel is our vision and how we seek to serve our community. We want to be compassionate to our patients' needs, to their pain. Folks with chronic pain have major impacts, not only on their pain, but in their lives, their mental health, and their relationships with others. And we try to do this not only by being compassionate, but by using innovation to maximize people's pain relief as best we can as well. And I think spinal cord stimulation really is on the cutting edge of these types of technological breakthroughs that help folks with chronic pain. So today we're going to talk about several things. We're going to try to understand a little bit better the stepwise approach in the treatment of chronic pain. And then I'd like to talk to you about the benefits of neurostimulation and that not all stimulators are made the same. We'll also talk about the temporary evaluation and trial process of spinal cord stimulation, and then what happens during permanent implantation. So this graph seeks to kind of talk a little bit about how chronic pain used to be treated and how we've changed that now. Historically, it involves sequential testing of different medications, basically, and we would work up through that. There's a WHO ladder for those types of medications, and that was really the mainstay of therapy. Spinal cord stimulation at the time, several decades ago, frankly, was really a last resort kind of treatment. And as a result of the changes and the efficacy that has been improved, that's occurring much sooner. And of course, with the opioid epidemic, we want to address things to try to treat pain without getting people dependent upon medications. So as you look there, conservative therapies, physical therapy, over-the-counter things like non-steroidal anti-inflammatories, Tylenol, things like that, and psychological therapies can be very crucial in treating chronic pain. As we move forward, these are more invasive therapies like injection therapies, epidurals, different things like that, TENS units, which work superficially, neurolysis, which is burning of nerves, things like that, and then thermal procedures similar to the neurolysis, which is more of a surgical kind of thing. Spinal cord stimulation has moved into a more conservative type of care rather than the aggressive care, which is in our step 3 here with chronic opioid maintenance, which develops long-term dependence and tolerance, as well as intrathecal therapies and surgical interventions. What is spinal cord stimulation? Well, it's a non-opioid alternative. It's a way to manage chronic pain. It's a wonderful way to test drive this technology to see if it works for people before permanent implantation occurs. And it's been used for decades. There are greater than 50,000, in fact, I'd say greater than 100,000 people that are living with permanent devices now. Neuromodulation is based on the gate control theory of neuromodulation. Melzack and Wall developed this theory in the 1960s, and it talks about input that's non-painful closing that gate to the painful output from those areas. The strongest signal wins, basically, goes through the spinal cord up to the brain. So this type of technology or this type of treatment intercepts the pain signals and blocks it before it reaches the brain. and diminishes the feelings of pain. It developed many therapies as a result of this theory, including spinal cord stimulation, but also peripheral nerve stimulation and TENS units, which many of you have probably tried or have heard of. Some people call it, is it a Band-Aid? I would argue it is not. It is a treatment to help block pain signals. Who's a candidate? Well, typically, someone who's had chronic pain for longer than 6 months and that hasn't responded to more conservative treatments. Other things that can make you a good candidate would be neuropathic pain. And there's different types of pain. We call them somatic, neuropathic, other types of pain. And it's characterized by burning, aching, numbness, and tingling sensations in the back, legs, or arms and feet. Failed back surgery syndrome is one of the first indications for spinal cord stimulation. Peripheral neuropathy is can qualify you for it and make it, it's a very good indication for it. And there's new evidence coming out that this could be a very effective treatment for this. Peripheral ischemia, phantom limb pain, and chronic complex regional pain syndrome. It's also crucial to understand that the patients that get little or no relief from surgery, pain medications, nerve blocks, TENS, or physical therapy would be excellent candidates for this treatment. Who might not be a candidate? It's always hard to hear when you hear about a therapy that's as impressive and promising as this. But folks that get a poor response when the trial is performed, and we'll talk about that in a little bit. Also, patients with untreated drug addiction problems. And again, the crucial part here is drug addiction. And addiction speaks to misuse of medications as opposed to patients with tolerance or dependence on medications. And with opioid therapy, that almost immediately happens. So that's a crucial distinction to make. And then patients with significant psychiatric problems are not excellent candidates for this. Which therapy is right for me? As we'll speak about in a little bit, there are different therapies and different programming systems and algorithms that are in place in spinal cord stimulation. As few as 5 years ago, all spinal cord stimulation was pretty much the same. There were some little tricks, some little tweaks here and there, but very similar. And we couldn't really tailor the appropriate modes for different patients and their different pain levels, locations, and types. Now, there have been several advancements in technology that allows us to apply the right therapy to the right pain pattern and presentation. One of these is HF10, or high frequency stimulation. The HF10 stands for 10,000 hertz, or 10 kilohertz. It's a high frequency stimulation that differs from previous stimulation, which caused a buzzing sensation to kind of overwhelm the pain signal. At this higher frequency, basically it scrambles the signaling of the pain as it goes up into the spinal canal. It works on the nerves differently, and it's highly effective for both back pain and for leg pain. It's an FDA-approved labeling. It says that it's superior to traditional spinal cord stimulation due to increased pain relief. As I mentioned before, paresthesia-free, and patients can leave this on 24/7, including when sleeping or driving. And that's something that comes up, do I have to turn this off when I drive? Do I have to turn it off when I sleep? And the answer to both of those is no. So we look at these graphs. Some of this just looks like a tornado to you, I'm sure, but it talks about some really crucial things here that we'll talk about. In terms of the graph on the left, talks about a higher responder rate of 76% than traditional spinal cord stimulation subjects, which is impressive. So that means more patients respond to this. And then back pain gets reduced as well at the 2-year mark. And you can see that difference as you put it over there. So people respond and they have increased pain reduction in 24 months. So that's that blue area as opposed to the green area, which is with traditional spinal cord stimulation. So I think this is really impressive and really documents what we're all so excited about with this therapy. For leg pain, similar kind of findings there with the 73% responder rate. So more people responding to it than spinal cord stimulation or typical spinal cord stimulation. One of the other leaders in the field is Abbott, and their stimulation is trademarked as burst DR. And this is a naturally occurring thing, and it's interpreted differently than that tonic stimulation that I mentioned before, that buzzing sensation. And when it fires, basically it fires, waits a little bit, fires again. What it does is it blocks that pain signaling, and then before the pain is able to be transmitted again, because there's always this refractory period within nerves, it buzzes again. And so it stays one step ahead of the pain. And it's very effective for leg pain and back pain. And may also help with emotional responses to pain too, which is very interesting. DRG stimulation. This is another one of those impressive breakthroughs recently. So this focuses in on the dorsal root ganglion of the back and the spinal nerves that come out. And basically this is like a central processing zone for pain, sensory stimulation, things like that. And we've been able to map out specific levels that control pain coming from different areas, including up higher in the abdomen, groin, or back. And as we go down lower into the lumbar spine, the leg and low back, or the feet, things like that. And sacral nerve stimulation is also possible to help out with different kinds of pain in the hip or in the pelvis. Peripheral nerve stimulation is another fantastic option. StimWave is one of them, one of the first ones that offers an implantable stimulator and receiver system with a wearable antenna assembly. Another one is a company called Nalu. And these are implanted, again, similar testing or a trial period to see if this is going to be helpful and would work before it is implanted in. It's got wearable technology, so basically on the outside, there's very little evidence that there's anything on the outside besides the wearable technology. StimWave has a belt. Nalu has a therapy disc that sticks on with an adhesive. And then there's a program controller that can be used to change algorithms or address and turn on and off the system. So what do we do when we talk with folks about trying spinal cord stimulation? Well, before the trial ever can happen, we do a physical screening. And this is the really crucial part of it. A diagnosis needs to be done. And we need to examine the patient. We need to talk about that individual's pain presentation, their symptoms, how this impacts their life, and see if this is a good option for them. We talk about the previous therapies that have been done. And we do a multidisciplinary screening if the patient seems to be a good candidate. And that includes the psychological evaluation. And I think you might remember me talking a little bit about that. The patients with significant psychological diagnoses and illness may not be the best candidates for this. This needs to be done before insurance will authorize this procedure. Additional imaging, including low back or thoracic, kind of mid-back, MRIs will probably need to be performed. And this allows us to evaluate your anatomy and make sure that we would be able to perform the trial and hopefully implantation of a permanent device. From a physical screening standpoint, if no contraindications exist, then we'll tailor that neurostimulation, both the device and the programming, to your pain. The psychological screening, as we talked about, rules out pathology and then identifies other secondary issues such as unrealistic expectations or an inability to understand what the spinal cord stimulation might allow people to have. For folks that think that they might be able to finally learn to play the piano or this will fix all of their ills in the world, that might not be the best candidate because we want to be realistic. We don't want to take something for granted or to really make any promises that spinal cord stimulation can't live up to. For the trial, Whether it's spinal cord stimulation or peripheral nerve stimulation, which does not go into the back, but goes overlying the nerves that are causing the pain. It's an in-office procedure. You don't need to go into the hospital with temporarily placed epidural leads. So the term we use for that is percutaneous. So if you hear that terminology, it means we go through the skin. And it's similar to what an epidural steroid injection is done in terms of the placement. We usually give some patients some sedation, and then we'll place under live fluoroscopic or X-ray guidance these leads, which are about the size of a spaghetti noodle, and we'll place those up carefully into the back. And usually they go about the mid-back to the T7, T8 level of the back, which is right around the bottom of your shoulder blades. The trial period at the Pain Institute of Southern Arizona is typically 7 days. This allows the patients to get over the procedural pain, which lasts about a day, maybe 2 days, and then work through different programs, different levels and algorithms to treat the pain and see what works best for you. The main goals are an improved quality of life and at least 50% reduction in pain to qualify for permanent implantation. We, of course, try to go for much better than that. Here's some images of how that looks from an X-ray standpoint. On the left, you'll see 2 straight lines there, kind of an upside down V. And those are the epidural needles that are going into the back. And then there are some thin lines with then some dotted lines there at the top. And those are the leads. Those are the contacts that send the signals to scramble that pain signal going up into the spinal cord. And you'll notice in the middle, another kind of view of the same thing. And then on the right is a DRG lead. And that's a smaller lead, almost like a thin wire with 4 contacts that go in underneath where that nerve root comes out from the spinal cord and applies directed spinal cord stimulation to those dorsal root ganglia. The components of an implanted system are important to kind of understand what would be planted in. As I mentioned, the leads, these thin wires with a kind of a elastic or rubberized coating, and there's those contacts there. Typically, they've got 8 contacts on each. The leads are placed around the epidural space in the spinal column. There's a generator or an IPG, sometimes we'll refer to it as the battery, but it's a miniature computer and battery all in one that looks similar to a pacemaker, if you're familiar with that, and it sends the pulses in the programming to those leads. The patient controller is a device that lets you adjust the therapy. What happens after the evaluation period? You'll come into our office, again, no need to go to the hospital, but we'll remove that system. The battery or IPG has been placed on the outside of the body, kind of taped on the back. We'll remove those leads out of the back, ensuring that everything goes smoothly and that everything's in place when it's removed, and to check for any signs of infection or pain. And then we'll talk basically with our team and you about the experience of the stimulation and whether it worked for you. Did you have 50% improvement and quality of life improvements that would make you a good candidate for permanent implantation? So for real life examples, we had advocates that can speak to this. Each company has different people that have had these implanted, and sometimes people that have had implantations from other device manufacturers to talk about the benefits they've had, and then the real world questions that you have about spinal cord stimulation, including costs. When do I have to have this done? How long can I expect to have pain after the procedure? Things like that. Some questions have been sent in, which I'd like to answer if I can. And I'm going to exit out of this if I can. One of the questions is, I've trialed a different system. Can I still try this one? The answer is yes. Because HF10 is a high frequency system, if you've trialed something in the past, whether it's a lower frequency or a tonic system previously, and either didn't get good relief or didn't feel like it was a good option for you, There are other options to retrial. So I think that's a great question. You could try a low and a high frequency. Another question here, how long does the battery last? So for the Nevro system, it lasts about 10 years. It is a rechargeable system, so it gets recharged. The Abbott system, if it's a non-rechargeable system, doesn't last quite as long because the battery may get the energy pulled out of it. And so lifetime for that, between 3 and 6 years probably before that needs to be changed out, depending on the amount of use and electrical impulses that are put through it. Can I have an MRI? Yes, these devices are MRI conditional, but they do allow for MRIs to be performed. Can it be taken out if I don't need it later? Yes, it can. And that's a crucial thing too, especially if it's placed percutaneously with those leads there. Those can be removed and the battery pack pulled out as well. And then the other question, I kind of touched on it a little bit. Can I talk to a patient who has had this done? Absolutely. Those the manufacturers, including Nevro and Abbott and Medtronic and others, have patient ambassador programs that can connect you with the people that have had these devices placed and talk to you about their experiences. So I wanted to thank you all for coming and listening to my invitation and talking about this. We have some spinal cord stimulator webinar team that's ready to talk with you. If you'd like to schedule an appointment and see if spinal cord stimulation might work for you, and if you might be a candidate, you can dial 520-345-5100 or email us at appointments@pisapain.com. Again, thank you. Have a great day.